All right, wow, it's 5 o'clock on the dot, everyone. I'm delighted to see you all here now. Thank you to those who are joining us from the other session, and welcome back to those who stayed on with this one. Just in case you haven't met me yet, I'm Margo Pearce. I'm a settler person. I'm here presently on the unceded traditional and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I'm also a research and evaluation specialist with Indigenous Cultural Safety at Fraser Health. And I'm just delighted to meet our next presenter today. This is Kathleen Lounsbury, who is speaking to us about a conversational analysis of community health nurses and systems change in First Nations communities. And Kathleen has a wonderful experience in her life, and she is a Kwakwaka'wakw woman from Numgis First Nation, and she has a long career in nursing and a passion for nursing research, and she recently completed her master's in nursing from Trinity Western, and she works very hard to educate about Indigenous perspectives and equity within healthcare. And just an amazing person. I'm really excited to meet you, and I'm so glad that you're here today to talk to us. And so I don't want to take up any more of your time. I will pass it over to you, Kathleen.
Okay. Gela Kesla, thank you very much. I'm just so excited to be here today, and I was so pleased to be invited here today. And I'm just going to get ready to share my slides. I want to get into it right quickly because there's a lot to share, and I'm sure there'll be a lot of questions afterwards. And I will introduce myself, along the way as part of my Indigenous research process. So I'm just going to screen share here and find my there we go. And so then we're going to go to slideshow and then start at the beginning. So hopefully this goes. Here we go from beginning. Wonderful. Okay, so again, this is the yeah. So I'm going to, looks like I have to. I'm the host. I see. Okay. A conversational analysis of community health nurses and systems change in First Nations community. And so this was my research project. This is my graduate research project that I had worked on and had struggled to get through as an Indigenous person working in a non-Indigenous context. And so, sorry, is there someone else that can admit people? I find that I'm needing to admit people while I'm speaking and it's distracting.
Don't worry about it, Kathleen. I can admit people for you.
Okay, great, thanks. I didn't know if I needed to do that. I was like, then okay. And so Indigenous protocols. So allow me to locate myself to you as an Indigenous woman and a community health nurse who's worked in several First Nations communities here in BC. And this picture here is of my maternal grandmother from the Musqueam people. I am originally from the west coast of Vancouver Island. This is my family. So on my mother's side, we're from the Kinkum Inlet area. And on my father's side, we're from the Numgis First Nations and the Mamtakela Slawikis people on that side, just up on the northwest coast of Vancouver Island. And so this is my elder brother, who is Lloyd Waters Jr. My father was a noted artist on the west coast here for many years. He's and created a lot of totem poles in and around different communities here. And so I come from a very rich background, a very proud background, Kwakwaka'wakw heritage. So I wanted to state that. And then, so the present day climate of healthcare delivery is due to the historical past practices of discrimination, isolation, and neglect. And we talked a lot about that already. And so in my project, I source, talk about the Indian residential schools and the Indian Act, assimilation policies and land placement. And then, because of the health disparities that, of course, rose up in this, in that environment, there's a lot of ways in which the Canadian government was trying to rectify those disparities. And so I tried to find things out. And the Royal Commission on Aboriginal Peoples, the Idle No More movement of 2012, the Truth and Reconciliation 2010 all the way to 2015, and of course our First Nations Health Authority came into implementation in 2013. And I also want to just mention it here, because I don't think I've mentioned it earlier. Part of the story of what happened in the Indian residential schools, I have both parents of mine were survivors of the Indian residential school. So, you know, I carry some of that trauma and the intergenerational trauma in my family and in my what I even do with my children to this day. And so I just want to talk a little bit about how the stories came to be, how that started to come up. And it was through Alcoholics Anonymous. I just want to mention that because I think that's just, you know, within today's climate of the Indian residential schools and the stories, a lot of things started to come through. And I wanted just to acknowledge the Alcoholics Anonymous program, because they started to dig deep and find out, you know, why is it that you're doing this? And why are you having such unhealthy behaviors? Why don't you care about your health and your family? And you know, what is it that you're running away from? And so I just wanted to make note of that here. And so my research, I wanted to talk about the First Nations Health, or actually do a compare and contrast between the First Nations Health Authority and the Health Canada model. And so we're going to talk a little bit more about that going forward. So the FNHA was established in 2013 with 7 directives. And for many people, they don't know what the 7 directives are. So I'm just going to mention them here. Directive 1, that it be community driven and nation-based. They wanted to increase decision-making and control, you know, and leave that in the hands of the First Nations people. They wanted to improve services. They wanted to foster meaningful collaboration and partnership. They wanted to develop human and economic capacity. That is a huge piece. Well, all of these are important. Be without prejudice the First Nations interests, and function at a high operational standard. These are the 7 directives that were given by the people for the people. And so definitely a very different process than the Health Canada model, which is very top down. And so I wanted to share that with you. Why do this? The study gives insight into how community health nurses, their leadership skills are identified and enacted, and how those leadership skills could be strengthened, particularly in the context of the changes in delivery of Indigenous health. And so I was starting to question, okay, what is it that we want to know? And so during my studies at Trinity Western, you know, we're talking a lot about leadership and leadership skills and how to be a leader and what does leadership look like in nursing. And I had a lot of questions for myself and for, you know, what things were drawing me, what drew leadership out of my own life and my own being. And so I wanted to know about the community health nurses, you know, what were their experiences, you know, adapting to these systems change, because it's a complete reversal of what they were used to. And so it, you know, it would be nice to hear from community health nurses how they were, you know, practicing in the new environment. So I want to just talk a little bit. This is the video there is just the people who have spoken into my life and people who are part of my research, my literature review. And so there's a lot of people there that you probably recognize and know. And this is sort of my Indigenous way of trying to do a literature review for you to kind of just see faces, because to me, the faces say a lot. And I was talking about these people and reading their work, and I was like, what do they look like? That's just part of my Indigenous heart. So that's my lit review right there. So what is known? And so I was very aware of whose shoulders I stand upon. And so my Nino Sola, my wise ones, I of course asked them and talked to my family, talked to my elders about, you know, what they understood health to be. And, you know, a lot of times they weren't asked those questions, and you could hear a pin drop in some of those meetings because they've never been given a platform to speak. And so, I you know, it was very interesting. And so the 4 years of literature review included, I was trying to figure out how to bring this together. So I tried to look at complex adaptive systems thinking. I looked at nursing leadership knowledge, community health nursing knowledge, and then Indigenous knowledge. And so I was bringing these things, trying to bring all of these things together to kind of come up with a question, come up with how I wanted to go forward and what was known about systems change in an Indigenous context. Framing the knowledge from an Indigenous perspective developed as I learned from those scholars who began to write their own research journey. And during this time, I was developing as a researcher myself, and struggled with trying to take these wonderful stories that I got and that I received, these gifts of data, and it was very hard to try to put it in a Western context. And so I was walking through that struggle, that journey at this time as well. So, so that's part of my journey. So thank you for that. I wanted to say thank you to all those people who wrote wonderful books. They're marvelous people. So we move on to the research method and the conversational method with data lensed as gifts. And so, and here again, we have two-eyed seeing. And so as I was going through my journey and, you know, grappling with how do I tell these stories in an authentic way? How do I stay true to what was given to me and find a way in which to go forward and to share that story, because I wanted to be very respectful of the 6 stories that were given to me. And so I struggled, but, you know, of course, my leadership at the school at Trinity Western, you know, I want to, you know, raise my hands to them because they began to say, no, there's other Indigenous modalities that you can take a look at, and we can begin to analyze your data. And that just opened it up for me. It changed my world. So we had 6 conversations that unfolded that blended Indigenous and Western ways of knowing, called two-eyed seeing. Also, Margaret Kovac approach called for locating the story in the conversation with the added awareness of the researcher's own knowledge systems in play. So you wanted that in there. I struggled for quite a while to find the right way in which to honor them, and a way that was congruent to my Kwakwaka'wakw background. So we had 3 community health nurses and 3 stakeholders share their leadership knowledge, their adaptations to systems change, and identify places of hopes and barriers to change in their settings. And so it became quite a journey, and I'm so excited to share this with you today. And so, of course, throughout today, we've talked about Indigenous research considerations, and we've gone through a lot. Of course, we talked about OCAP early on. But I wanted just to bring something to your notice, and that is Margaret Kovac's at a university, I think it was at UBC, kind of presented the benchmarks of Indigenous research. And I just thought I would introduce those to you here because I found them to be quite profound for me. So the protocol of introduction. So I situate myself with my kinship and my relationship to my research in chapter 1 and in chapter 4 in the conversations. And so this was so powerful for me because I didn't have to, I could be part of the research. I could be part of what was going on. The statement on preparation spoke to me of our knowledge keepers, and we call them our Ninok Sola in our language. Read many works of a lot of Indigenous scholars, Wilson, Voyager, Kovac, and of course my own journey of Indigenous conscientization. So Indigenous Epistemology and Theoretic Foundations, I reference Indigenous world philosophy throughout, especially in chapter 4 through 6. The work of Kenny and Fraser in leadership was phenomenal. A story as inclusive to the whole research work. And then of course the conceptual framing. And what makes sense to Indigenous peoples. I wanted to use something that made sense to me. Oh, you should have seen the things that I did during this time trying to conceptually frame my work. I did all kinds of charts and I did all kinds of angles and I tried to do all kinds of different things. It just was so linear and just did not make any sense. So what I ended up doing, I plan to do oral dissemination and reciprocity in sharing the image of a tree. So and that again just helped so much in my journey of putting analysis and understanding of what I was hearing from my participants and bringing it out in a way that Indigenous people, our people, could understand. And so so from a linear approach to one that is definitely a more Indigenous one. Wonderful. So I'm going to introduce to you my participants. We have Nellie, and she is an Indigenous First Nations Health Authority champion and director who communicated confidence in the organization's 7 directives and emphasized the importance of addressing intergenerational trauma. Next, we have Ed, who was a senior Indigenous community leader who emphasized healthy systems with a high operational standards because of his own distrust for governmental systems. And he has, we'll share a little bit more of his story. Then we have Darlene. Darlene is a non-Indigenous PhD prepared leader who is viewed as a change agent in where she works. And also for me, she's very systems thinking, she's self-directed, and she values teamwork. She has a grasp of both systems, both the FNHA and the Health Canada model, and has learned to navigate between them. Then we have Mercy. Mercy is a non-Indigenous community health nurse who is very experienced and systems critical. And Mercy, how we came upon her name and, through our discussion was, she talked a little bit about her own journey as a community health nurse, moving and going around. And I actually had a hard time with Mercy when I first interviewed her, because the way she talked about how she was going in and out of Indigenous people. Oh, I had this gig. Oh, we're going to do this. And so it was very, to me, very abrasive. And it took me a little bit longer to understand where she was coming from, and that how she really didn't want to continue to be a part of the status quo that was continually hurting Indigenous people. So she tried to sort of distance herself. But, within that journey of herself, she, the people said to her, you're like a mercenary to us. You have a mercenary attitude. And she, thought about it for a second, and she acknowledged that, yes, you know what, they're right. I can see how I could be that way. And so when I talk a little bit about, my journey with her and together, how we came to for me to understand who she is in this study. Next, we have Gina. Gina is non-Indigenous CHN who practices in an Indigenous context with enthusiasm and openness to see work differently. And so she was up north, and she was in the, not in BC, but she certainly has something to give to us. And then again, we have Jess, who is non-Indigenous community health nurse who coexists with the people she serves. So she actually lives in the community. She lives with them on a day-to-day basis. So she has a personal investment in their future. And of course, she lives in a northern community as well. And so now we're going to talk about the tree and the 2 different trees. And so this tree is the First Nation Health Authority model. And I want to say that, you know, with the values that were given, you know, the 7 directives. And so you can see the 7 directives. If you take a look at that, the FNHA 7 directives, and you see how, you know, it's from bottom up. The words are going upward. So that's coming from the community, from the heart of fresh, hot off of their hearts, the people's hearts. And so it is rooted in traditional governance, ceremonial practice, rich cultural history, healthy identity, cultural values, and traditional teachings. And you know, and it's really quite fascinating to you know, to hear and to see things that are coming out of the First Nations Health Authority. It's not a utopia, but it's something that we can definitely launch our future out of. And so here we have also our knots, and these are the things that are sort of identified barriers and identified things that, you know, may could trip us up. You know, we have to be careful of them. So that is the intergenerational trauma for First Nation clientele, echoes of the old system in the new system. We have, there's low systemic capacity for, you know, just for further, we need to continue to grow our Indigenous capacity in the healthcare field for sure. But I also want to just say here that, you know, when we talk about the tree, I did some research with Ms. Samard out of UBC. She's our tree, you know, our lady that loves the trees, you know, and she says that, you know, before there was sort of an understanding that, you know, trees, it was a survival of the fittest, and whoever got the water, whoever didn't get the water died. But she said, no, trees live in a community too. And in community, there's a mother tree, and in the mother tree, you know, she actually manages the whole community of trees. And I just thought that was so fascinating, you know, and wanted to kind of just bring some of that knowledge in this example here. And that, you know, trees live in community, and they have an underground network for communication. And so CHN stakeholders should create spaces to empower their community to live healthy lives. That's sort of the underground network and the things that we can do to network with one another. But I also want to just, you know, as we go forward and we take a look at the Health Canada model tree, you know, just to sort of see it that, you know, we could have this as a mother tree that can, you know, nourish and change the Health Canada model that the rest of Canada is using. Because the First Nations Health Authority here in BC is it's groundbreaking, and a lot of Canada is watching, you know, what we're doing here in BC. And so I wanted to bring your attention as well to that the decolonizing lens is nested within the tree, within the structure. And I wanted to point that out. And of course, we have some of the things that were identified by these stakeholders and the participants. And the things that they mentioned were that they found the crown of the First Nations Health Authority. What are the things that are giving life to the tree is stronger partnership accords. There's increased community engagement, a greater awareness of Indigenous knowledges and how that can fuel new practice and new understandings. It's very rich, increased staff retention. And throughout that, some of our fruit we have here are some stronger families, active lifestyles. There's a way in which, you know, we can move forward. And of course, there's a stronger emphasis on mental health in the First Nations Health Authority that wasn't there. It was very absent in the Health Canada model. And so a lot of change agencies, self-directed, leadership lens, a lot of things that are there that continue to grow and nourish our tree. And so this is the FNHA model. It's just something that, you know, I believe you know, there are ways in which we can really launch some greatness, even though we do have some ways to go. So now we're going to take a look at the Health Canada model tree. And here, of course, we see that the Health Canada system is very embedded in colonialistic ideology. We have the land disposition, we have an Indian Act, racism, all those things, okay, that are kind of killing the tree. And it's a very top-down system. Here, the nursing care is nested in tasks, so it's very task-oriented, and we understood that, you know, as we were talking to our nurses and our stakeholders. And so you can see that Indigenous people are treated as objects, very fragmented service delivery, paternalistic ideologies of leadership, and a lack of an identified mandate. And so here we have, you know, some of the fruit of this, of course, is chronic disease, violence, CHN burnout, infant and maternal mortality rates are of interest. And out here, you can see that the decolonizing lens is nested with the CHN. It's with the nurse. So it's not within the system, it's within the nurse. And so a lot of work has to go to help the nurse find her way. And so that's some of the things that, you know, a lot of things to discuss here. So I just wanted to mention that. So what did we learn about CHNs? And I'm just going to make sure I'm checking my time. I'm almost done. Here is Health Canada, very technical but lacking in cultural capital to affect meaningful change. The FNHA model, benefits of being able to view from a systems lens. Decolonizing is nested in the system. And so Jess has a very localized view of leadership. Gina, she's talking about moving the needle. Leadership is assumed. So this is in the Health Canada model. Mercy, not married to either system, very systems critical, where power is housed, doesn't want to be complicit in further harm. And so in our people for the First Nations Health Authority, we've got Nellie, who's very systems thinking, big picture, knowledge transfer, all of those wonderful things. Ed needs cultural, CHNs need cultural training to be ready to serve in the community. And Darlene is a strong pass with the Health Canada model, would like to see better management to further build capacity, mental health there. And so one of the things I wanted to bring about here, when I realize I'm running out of time, but I want to talk about research as ceremony, talking together. And so one of the things that I did as we were taking a look at the data and the people that were, all the stories that were talking, I wanted to sort of employ a analytic maneuver where I had the participants talking to one another and ending with a ceremony, because research is ceremony. It's a part of who we are. We just need to embrace who we are and how we tell our story. And so I wanted to bring some people together. So a healing circle for Mercy, because she needs to be mentored and given permission to engage. Digitot, which means our Digitot is a making things right ceremony. So we wanted Mercy to make things right, want to give her a ceremony. Have an initiation for Jess, Gina, and Darlene and Nellie to grant them entry into new practice paradigms. A mantling ceremony for Darlene and Nellie. This gives them power to water the tree and to, because they can see things. And I really think that they can move the ball down the field, so to speak. So I want to kind of give them permission to move forward. And then of course, Ed, to given to chiefs a head dressing ceremony to honor his commitment to his people, even through his distrust of the systems in place. And so I had different leadership lenses that I used. Of course, Benes, Grossman, and Valiga, traditional. And then I found some wonderful Indigenous people, authors, Kenny and Fraser, Kimmerer, and Ermine. And just amazing work that they did, and really helped me move my journey along in how I understood the data. And so I'm always grateful for authors and people who give back and share their knowledge and their knowledge keeping and the way they're gifted to give the knowledge back out to new research such as myself. And here there's a lot of implications for community health nursing leadership, as well as for systems policy, health systems policy. And of course, we want to bring in the Canadian Indigenous Nursing Association. Want to thank them. They're I think we need to align ourselves with them a lot more and use some of the wonderful knowledge that's housed in that association. So Gilak Isla, thank you for your time, and I will stop sharing. And if there's any questions, I'd love to hear from you.
Margo, I think we have time for one question before we move to the other room for the closing ceremony.
Fantastic. I'm sure I'm not the only person who's just riveted by that presentation, Kathleen. Thank you so much. That was amazing. Your journey, I was, hanging on every word. Do we have any questions from the Zoom audience in the chat? I just wanted to speak to you. I'll perhaps raise a question. Oh, we've got one, I think. Oh, just sincere gratitude and thanks for this amazing presentation. I wanted to ask you a little bit more about, like I said, I loved the tree diagrams, and I think it's so wonderful, like how much they're, like I could really envision what you were talking about. And then when you came along further to talk about how you integrated ceremony into the research practice and how it lines up with it's all connected, I guess is what I'm coming away with. And I just think that's brilliant. And, you know, giving time for systems change to happen, I think is something that's really, really important, that, you know, FNHA is really new, and there's a lot of work that's being done within the organization and that. And I guess I just wanted to ask a little bit further about if you have any comments about how FNHA does it differently in supporting nurses to, I guess, to work with community and to do their work in a good way.
Yeah. So actually, one of my participants stated something I thought was really quite profound, and this was Mercy. She said that, you know, one of the things that helped me, you know, because she went through a lot of trauma and things like that in her own nursing practice, and sometimes things were very unsafe. And so she had to find ways in which to find safety, and there are things that happen on reserve. So she said that there was a discussion that happened within the First Nations Health Authority that would never have happened in Health Canada, the Health Canada model. She said, when I was there and we had a conversation to discuss my issues, there is no way that would have happened in the old model, but there was a freedom and there was a platform for her to share and for them to deal with the issue for her. And so I think that, you know, because it's rooted in doing traditional healings and they give room for Indigenous knowledges, I think that is probably going to be one of the powerhouses of the First Nations Health Authority down the road.
That makes so much sense, because it won't burn people out. Like all the pressure that the federal system had, or the government system had on putting it all upon the community health nurse to do this work, whereas FNHA is coming at it and like, here's a whole system designed to let you do this work in a safe way. It's, thank you for that. We have another
Margo, I think to cut us short, but
shoot. Okay.
The other session has concluded. So we do need to move over to the closeout session. So to everyone, just to remind you, it is a separate Zoom link. It's the same link that you used this morning for if you attended any the keynote this morning or the welcoming ceremony this morning. So please see your agenda for that Zoom link, and we will see you in a minute over there. And thank you so much, Kathleen.
Okay, thank you.
Kathleen, that was brilliant. Thank you so much for sharing.